Hi everyone, my name's Graham and I do some training for Dovetail medical events. One of the components or small sections that we cover is understanding vitamin B12. So as I've said in the other snippet that I did, the introduction one on how to read the results, it's worth reading that one or viewing that one first, and then if you come back and have a look at this one. So I said in the other section, I do training for Dovetail around interpreting blood results and ECGs. And one of the things we talk about is vitamin B12. So the aim of this short snippet is to have a look at what B12 is, some common symptoms, some common deficiencies, how would they present, and having a look at basic blood tests. We'll also have a look at things like injections. People love their B12 injections, so we'll have a look at that as well. So have a look at some additional information to go along with this session. So there's a website called Lab Tests Online, made by the NHS. It's really helpful and it's an A to Z of any blood test you'd ever want to do. So have a look at that if you use Lab Tests Online. It's free, not for profit. The web address is labtestonline.org.uk. I've also written a textbook which is called Blood Results in Clinical Practice. And again, have a look at the NICE guidance for vitamin B12 and then have a look at how that's locally applied. So, for example, the national guidance might be slightly different if you're in Scotland, Wales, Northern Ireland. And again, the new NICE guidance for vitamin B12 is very helpful. But it talks about two new things. It talks about active B12 and a B12 value which is low but in range. So they're kind of two new things. It also expands a bit more around metformin, which is a drug used in diabetes, and the use of injections. It is national guidance, and have a look at how your GP or local practice or diabetic team have locally applied that. And as with all of these sessions, this is not medical advice specifically. This is a CPD workshop with the aim of linking the blood test to the underlying anatomy and physiology. So if you've got a pathology chart, local guidance, approved protocol, then always follow that over any information that we're going to talk about today, because obviously I can't see the patient and I'm giving this discussion sort of as a workshop. Okay, so what is vitamin B12? So it's one of the most important water-soluble vitamins, and it has several key functions. So it's really important for red cell production. It helps with nerve function. So my headphones have a little electrical cable with the electrical wire running through the middle. And this red bit on the outside is the insulating part. So it means I don't get electrocuted, but it means the electrical signal can pass through this wire unimpeded. Our nerves are the same thing. So we have the electrical component in the middle, which is like different salts, synapses and things. And then we have a insulating part, which is called the myelin. So it's called the myelin sheath. And this is made by vitamin B12. So it's really, really important for nerve function. So one of the most important red flags with B12 deficiency is any new nerve damage. It's called neuropathy. This is particularly problematic in people who are withdrawing from things like alcohol or misusing nitrous oxide. So yeah, if your person has any problems around alcohol, then that would normally be escalated. The other thing vitamin B12 does is something really boring called the Krebs cycle. So it helps with the metabolism of other chemicals like glucose. So glucose, oxygen, B12 all help to provide energy and really boring biochemistry, things like ATP, muscle power, muscle energy. So B12 has three jobs to do: making red blood cells, helping with nerve function, and in its own right, giving us energy. And as we see in other training sessions, other nutrients do the same thing. So, for example, iron helps with red cell production. Iron helps with inflammation and infection. And iron in its own right can give us energy. So, not everybody with a B12 or iron deficiency will necessarily have an anemia, and the other holds true. Not everybody with anemia has a B12 or iron deficiency. So, we'll explore all of that in more detail. We need to get B12 externally. We can't make it ourselves. So we need to get it from dietary sources or supplementation. So vitamin B12 main role is around red cell production. And a deficiency of vitamin B12 leads to something called megaloblastic or macrocytic. So megaloblast is quite an old-fashioned phrase. You don't tend to use it very often. Instead, we refer to them as macro, which means big, and then cytic, CYTIC, which means cell. So big cells, we'll talk about why that is a little bit later on. So you end up with less red blood cells, but the ones you do have are bigger. So they end up with low hemoglobin, so anemic, but they have a high mean cell volume. So again, we'll explore that a little bit later on. Vitamin B12 is needed for cell division and DNA synthesis. So this is part of the problem around supplementing with folate. So folate and B12 together are called hemotinics. And a good way to remember this if you're going to supplement is before. So if your person is deficient in B12 and folate, check local guidance. We normally replete or fix their B12 before folate. There's a boring biochemical reason why we need to do that. It's essentially to do with DNA nerve damage. So B12, recover that first generally, and then folate second. So if you look at the word before, B comes before F. So do B12 before folate. Like we said, myelin formation is absolutely critical in B12. So have a look at any nerve damage would be escalated, any neuropathy. And because B12 is water soluble, it's mainly stored in our liver. And the liver can store B12 for about 2 years. So it could take a while for a B12 deficiency to show. So if you stopped eating vitamin B12, it might be a year, 6 months, 18 months before you start to feel the impact of that deficiency. Because effectively we're hunter-gatherers, so we're built to kind of eat food when it's seasonal and when it's available. So our liver is our body's store cupboard. It stores iron, B12, stores vitamin D, stores glucose. So a lot of our key nutrients are stored in the liver. The additional part of this is pregnancy. So vitamin B12, particularly in the third trimester of pregnancy, there's a lot of cell growth and fetal nerve development. So there's often a large transfer of B12 from mum to the neonate, to the baby, to the embryo. So you have a look at pregnancy. It takes specific advice, but B12 deficiency is often very common in pregnancy. So where do we get B12 from? So we mainly get it from animal products. So particularly things like liver, kidney, really high in vitamin B12, pork, fish, eggs, and dairy products. However, a lot of cereals are called fortified. That means the vitamin is added afterwards. And a lot of plant-based milks, so like oat milks. And you can also get B12 from other vegan sources. So therefore, if your person was to have a new vegan or vegetarian diet, or if they had an eating difference called ARFID, so avoidance restricted food intake, so eating a lot of beige foods, then again, they may have a vitamin B12 deficiency. So people at risk of B12 deficiency, generally vegan, vegetarian. When you get to 35, according to the NHS data, you're officially old. So when we get to 35, we get an age-related absorption decline. So older adults over 35, but normally over 65, tend to have a naturally age-related decrease in B12 absorption. And lots of medical conditions and medication. For example, bariatric surgery or gastric sleeves, dysphagia, so kind of swallowing problems, and a commonly used drug in diabetes called metformin. They could all interact with B12 absorption. And there's also an autoimmune condition called pernicious anemia, which we'll talk about in a minute. Okay, so common symptoms of B12 deficiency is tiredness. TATT, tired all the time. Short of breath and linked to anemia. And if you watch the other snippet that I did, you could see that we might have to do a broader review of tiredness. So hemoglobin could give you low tiredness, could make you tired. Low sodium could make you low magnesium, low iron, underactive thyroid. So there's lots of things that can make you tired, one of which is vitamin B12 deficiency. Have a look for numbness, tingling, a gait, that's the way you walk, any balance problems, any falls. There's lots of new research looking at B12 and folate in dementia. It's not conclusive or definitive at the moment, but there's lots of research around memory, confusion, delirium, and could that be linked to B12? So you kind of add in, it makes you tired, short of breath, balance problems, confusion, um, makes your tongue swell, you get mouth ulcers, and that makes you not eat enough, so you get more of this. You can see you get stuck in this loop, and people can, particularly older adults, can then lead to falls at home and long lies and things like that. So we might want to get on top of this, trying to fix this before it gets too problematic and somebody's fallen over. Okay, in terms of key messages then, we said it's crucial for red cell production. And the red flag is nerve damage. Any nerve damage, escalate that and get on with treating it. Because B12 is normally from animal sources, without an adequate fortification, vegan, vegetarian patients are normally at higher risk. Older adults and people who have got a gastro difference, so a gastrointestinal tract difference. And being able to explain this to patients is very important, particularly if you've got something like pernicious anemia, they might need an injection instead. Okay, in the other snippet that I did, we spoke about this idea of a range hangover. So just to summarize that, every single blood test has this problem. So the reference range we use in practice does not reflect health. So this green line on the screen represents people with healthy liver, healthy B12. The red one represents people with a B12 deficiency. In this example, the high one is a B12 in excess. B12's got a deficiency, so let me draw that one. So that's this one. B12's got a low value. Let's draw that. And then where this green one overlaps, let's draw a vertical line. And then where these overlap, let's draw a vertical line. So let's just pause a bit and recap what we've done. So on the x-axis from left to right, we've got the vitamin B12 blood test results. From low to high. You can see in B12, there are two elements of B12. One when it's really high and one when it's really low. And both of those are diseased or abnormal. Okay, the green one represents normal B12 levels that are asymptomatic. So if it's green, they've got no symptoms. And if it's red, they'll have symptoms. Okay, where they've overlapped here and here, can see the red and green have overlapped. We've drawn two vertical lines. And like we said in the other summary snippet, this is the normal reference range we use in practice, which is normally 200 to 800. That's a normal vitamin B12 reference range generally, something like that. So the first thing we can note is, can you see this green healthy group extends past the normal range? So you can have a normal B12 level up to about 1,000. If you're on the B12 injection, that could be 3,000. And that's just reflecting the intramuscular B12 injection that you've given the patient. So in the longer training session, we'll talk about injections, when to repeat them, why people feel tired after 10 weeks and want a replacement injection. But yeah, if you're on the intramuscular injection, it's water soluble, your liver stores it, you need to give it loading doses to make your liver learn to store it, then yeah, you could have a B12 of 2 to 3,000 in the blood, which is normal, abnormal, but expected because you're measuring the injection. At the bottom end, this green extends down to about 150. So again, if your B12 levels are low, it doesn't necessarily mean you've got a deficiency. Some people have low B12 levels that are completely fine. So again, generally we tend to go, is the result under 150? The interesting part in the new guidance are these. Can you see these people here? Can you see they're unwell? They're tired, symptomatic. But can you see they've got a normal B12? So we think that this red, unhealthy, tired group goes into the range to 350. So just to note, although the normal reference range for B12 is 200 to 800, you could, in theory, still be symptomatically tired with a B12 of 200 to 350, even though that would come back on the lab result as normal. So have a look at how your GP practice is implementing that guidance. Okay, so just to summarize this slide then, we've said that the range using clinical practice is just a guide, and have a look at, is your person tired? What impact has B12 got on hemoglobin production, nerve production? Does it make sense? Have they got gastric surgery? And just to note that most people have a B12 value low, but some people can have a B12 value which is in range, but they're still very tired. Okay, in the larger session, we'll also look at anemia, and we'll split anemia into three parts. So the first thing we'll do is we'll have a look at, are they anemic, by requesting a full blood count and seeing, have you got low hemoglobin? Second thing we'll do is we'll have a look at the size of the red blood cell. So this will tell us which type of anemia have you got. So this first step, step number one, that's to confirm anemia or diagnose it. The second step is to work out which type of anemia you've got. And for today, we're talking about this type. So the blood test result will be low hemoglobin, high mean cell volume. So you've got less red blood cells, but they're actually really big. And this is normally due to a deficiency in either folic acid or vitamin B12. So again, in the session, we'd be interactive around this, and I would pause and discuss it with the group. And one of the things we'll explain is, why is it called macrocytic? So again, if you want to pause this video and reflect on why is it called macrocytic. So we said macro means big and cytic means cell. So macrocytic. Okay, the final part of this is we'll also talk in more detail about pernicious anemia and how we absorb and store vitamin B12. So very briefly, just as a quick 30-second overview, if you eat dietary B12, it's absorbed via a chemical called intrinsic factor. And this is produced by the stomach. And then this binds vitamin B12 and allows it to be absorbed a bit further around at the ileum. So now we've got vitamin B12 in the bloodstream, and we said that's going to be used for cells, nerves, and energy. So we'll explore in a bit more detail. It could be dietary, for why you've got low B12 in your blood. It could be a swallowing reflux problem like dysphagia in Parkinson's. You might have a bit of your stomach removed, so gastric surgery. You might have a bit of your ileum removed. You might have a drug interacting with all of this, like metformin. Or you might have an autoimmune condition called pernicious anemia. So in pernicious anemia, the autoimmune condition blocks intrinsic factor production. So therefore, they really struggle to absorb B12 orally. So instead, if you've got any of this stuff going on, can you see you can't absorb B12 orally? It'll be quite difficult to do that. So instead, we'd miss all of your stomach out and give you the B12 directly as an intramuscular injection. That's going to be stored along the way by the liver, and then that will help to maintain appropriate B12 levels once you've done the loading doses for the next 12 weeks or so. So we'll unpack that in much more detail. We'll look at some flow charts around intrinsic factor antibody measurements, IM injections, and why people want their injections a little bit sooner. All right, hopefully this has been a productive short overview of vitamin B12, and it'd be really great to see you at some future Dovetail sessions. Thank you very much.